It's yet another face to put in front of you. I haven't had the chance to introduce myself to this group yet. My name's Philip Yeski. I'm the Scientific and Alliance Officer for the United Mitochondrial Disease Foundation. That's a new role that was just created last year. It really represents the first dedicated resource within the UMDF for science initiatives. I'm very excited to be on board. I had an affected daughter that passed away at age 1, so I'm very much connected to this community. I care very deeply about it, and I know there's some great things we can do together, and it's really about community. And this subset of the overall mitochondrial disease community is tremendous. So your passion for it and wanting to be involved is critical for our success in developing treatments and cures. And there are really exciting things coming, and particularly inside LHON. So please keep hope, stay involved, and anything we can do for you, don't hesitate to reach out. Lissa is a great, really a close contact for us, but if there's anything the UMDF can do, don't hesitate to reach out. So my role, very quickly, is just to introduce the speakers today, and you really have two top scientists, right, internationally renowned, that are presenting today. And the first is Dr. Valerio Carelli from Italy. Perhaps some of you are already familiar with them, but if not, briefly, Valerio has been a researcher in charge of the Laboratory of Neurogenetics at the Biomedical Sciences and Neuromotor Pathologies at the University of Bologna in Italy, one of my favorite places in northern Italy. Also part of the Faculty of Medicine and Surgery there as well, and focuses on eye disorders and LHON in particular. He's currently a research assistant professor of ophthalmology at the Department of Ophthalmology Eye Institute, University of Southern California Medicine, so also has very close contacts to the United States. And his background is a degree in medicine and surgery from the University of Bologna, specializing in neurology, and earned his PhD in neuroscience at the University of Verona. So you've really studied in some very, very, very nice places and live in a very nice place as well. So I think we should give a warm welcome to Dr. Carelli, and I'm sure he'll give a great talk.
Okay. So thank you very much for the introduction, and thank you to Lisa for organizing this, and I'm extremely pleased to see that each year this is getting bigger and more accurate, and I think it's going to be really useful because the community of the optic neuropathy patients has a number of peculiarities as compared to the other patients with mitochondrial disorders. And you need to share all these special issues that you have about this disease. So the title has been assigned by Lisa. I think want to clarify why. I mean, we have a couple of big questions with labors. Why not everybody gets the disease, and why males are getting more frequently the disease? So these are the two mysteries of labors. And I will try to drive you through this very complicated number of informations that we now have, and trying to pass you some messages about what is our understanding right now of labors. And I also want to point out that I just came back from the MitoCon meeting, that is the UMDF meeting, the analogous organization of patients in Italy. And next week, I will be going to EuroMIT, which is the European Organization of Mitochondrial Scientists and Patients. So I also want to disclose a relationship with some companies that we have been working with, and it's about labors and some molecules that might be useful for therapy. So this disease is called Leber's optic atrophy, but actually a few years earlier, von Graefe, another famous ophthalmologist in Germany, did describe these patients quite accurately. But then the name that is associated with this disorder is Leber's because he did the most systematic description of the disease. And he described very accurately the disease, and we still stick with the first description because he was really good. And what the ophthalmologists see in the fundus of the patients when they come to us complaining that they don't see in one or both eyes is actually something that, tells you that one part of the disease is already happened. So this is an important point because when we go and we will discuss therapy, when the patient is already symptomatic, we may think that it's already too late in some ways for very drastic therapeutic intervention. And you can recognize that some fibers on one side of the optic nerve head are lost. These are the fibers that bring the information about the central visual field, and because they're lost, the first symptom that the patients experience is that they can't see exactly in the center of the visual field. But at the same time, all the other fibers are sort of swollen, and this is the confounding factor for the physician because he thinks there is some inflammation, and this is why, in most cases, these patients are misdiagnosed initially as an optic neuritis, and they get treated with corticosteroids and may be told that MS is the problem, which in most cases is not. And the relationship between LHON and MS will be developed by Patrick later on. And actually, if you do fluorangiography, you don't see leakage of the fluorescent dye in the vasculature, and this means that you don't have a breakage of the blood wall, and this is telling you that you don't have inflammation, essentially. So you have to suspect that a neurodegenerative disorder is going on instead of the inflammatory disease. So since the beginning, it has been noticed that this is a hereditary disorder, but it was very difficult to recognize what kind of pattern of heredity was going on because the way the people was affected within families was not actually obeying the rules of Mendelian genetics. So this disorder cannot be classified as an autosomal dominant or autosomal recessive or X-linked. Actually, the closest thing that you can think of is an X-linked disorder. This means that if you have a gene in the chromosome X, the males would be more affected, and this is a matter of fact that is happening in labors. But for example, in this pedigree genealogy, sorry for that, the squares are males which are affected, and there are more than the females. You have just a couple of females affected in this family. But the most important thing is that you have a lot of other people which probably carry the disease gene, but they don't get affected. So since the beginning, you understand that there is a problem in what is the transmission of this disorder and why males are more affected than females and why not everybody is getting the disease. So over the years, it became clear that all people affected in a family were connected through females. So it became clear that the pattern of heredity was a maternal inheritance, and Dr. Wallace was actually the one discovering that there is just a little piece of DNA that is strictly maternally inherited, which is mitochondrial DNA. So it was natural that in a few years after this description, the best candidate for looking at mutations in mitochondrial DNA was Leber's hereditary optic neuropathy, because that disease was strictly inherited through the maternal line, exactly as mitochondrial DNA. And it's a matter of fact that in 1988, again, Dr. Wallace discovered the first mutation, the one that is most frequent and that we know by the number of 11778. So, since then, mitochondrial medicine developed very fast. That particular year, 1988, also deletions were discovered in mitochondrial DNA as cause of myopathies. And so now we have many, many disorders which are associated with mutations in mitochondrial DNA, but still the optic nerve is one of the very frequent manifestations. So you have to understand this is not limited to labors, but is a frequent occurrence as a symptom, as a manifestation of a mitochondrial disorder in syndromes like MERF or other mitochondrial diseases. And it is also true that Leber's hereditary optic neuropathy is not the only disorder affecting the optic nerve due to a dysfunction in mitochondria. You have a very close disease which is called autosomal dominant optic atrophy, where the affected gene is OPO1. In most cases, it's in the nucleus, so it's not maternally inherited because the genetic defect is actually obeying the Mendelian laws of heredity, and it's autosomal dominant. And then, as I said, you can have all these syndromes with optic atrophy, and I think Patrick Ueyman will be touching the point of Leber's plus, so syndromic forms of optic atrophy. But also you have to know that there are a number of drugs which are able to interfere with mitochondrial metabolism, which can also cause an optic atrophy, which is absolutely similar to Leber's. And many of these drugs are antibiotics. So again, we all know that it's a maternally inherited disorder. We now have 3 mutations associated in 90% of cases, and it's very selective. Just the optic nerve is affected. In particular, the central vision is affected, and only one cell type is actually degenerating because of this genetic mutation. But the points that we will discuss today is why males are more frequently affected than females, and why not everybody in a family along the maternal line is actually getting the disease. So back to the original pedigree I showed. Now we know that this is a family with Leber's, and everybody along the maternal line, so all the white symbols, male and females, they still have the mutation, but they're not affected, so they're carriers. And this family carries the 11778 mutation on a haplogroup J background, and we'll get back to that concept of the background, what it means. So from the genetic point of view, let's try to understand why only some people get the disease. So technically speaking, scientists would say that this disease has an incomplete penetrance. That means literally not all people having the genetic mutation will get the disease. And we will develop this issue looking at mitochondrial DNA mutations first. You need to have a mitochondrial DNA mutation in order to be predisposed to Leber's. But then it's also interesting to see that the remaining part of mitochondrial DNA is important, because mitochondrial DNA is a very variable molecule. Each of us has variants which make a difference between each of us, and these variants are clustered in what we call haplogroups. And this variability of the genetic background is also important for interaction with environmental factors. And we now know that there are some environmental factors which are triggers for Leber's. But finally, the big mystery, which is still unsolved, is if we do have something else in the nuclear genome, in the chromosomes, and in particular in the X chromosome, as initially discussed. So, as we said before, 3 major mutations are affecting 90% of the patients. And these are the 11778, 14484, and 3460. And now that the complex 1, the enzymatic complex which is hit by these mutations, has been better understood because has been crystallized. And we heard yesterday from Dr. Sazanov a lot of new information about that at the UMDF meeting, scientific meeting. Now we know that one of the mutations, the 3460, affects the site where the electrons, which are flowing in this complex, are being received by coenzyme Q. So this mutation affects directly the biochemical activity of the complex 1, while the other 2 mutations, if you measure the complex 1 activity, it seems to be pretty normal. But they are located in a part of the complex 1 where actually they may affect the translocation of protons. So this complex transfers electrons to lower state of energy, and this energy which is liberated is being conserved, charging like a battery the membrane of mitochondria. And this is done by pumping protons. So if you have a mutation in a certain location that interferes with this activity, you may not be charging so efficiently the battery. But you still have 10% of patients with clinically, if they come to your clinic, they're exactly the same as the other ones. They are labors, but they don't have one of the 3 frequent mutations. And in particular, if you have a maternal evidence of a maternal inheritance within the family, it's mandatory that you have to sequence the entire mitochondrial DNA. Nowadays, it's a simple thing because technically it doesn't cost that much, and it's feasible in a few days. And it's a matter of fact that we grouped a number of these patients with no mutation, and we found other primary mutations, which we call rare primary mutations. This was published recently, and it still happens that we find new mutations covering that 10% that has no of the 3 frequent mutations. And these mutations are clustered in 2 subunits, which are also hit by the 3 frequent mutations. These are ND1 and ND6. ND1 is the same subunit as for 3460 mutation, and ND6 is the same subunit as for 14484. So there are a number of other mutations which are in these 2 proteins still able to produce labors. And as I said, it's not only important that you have the mutation, which is a precondition in order to be predisposed to labors, but the variants that you may have within the mitochondrial DNA as a person, they may be acting as enhancing the pathogenic potential of the mutation or lowering the pathogenic potential of the mutation. And these variants are those variants which altogether define what we call haplogroups. The association of haplogroup J with 2 of the 3 labors mutation, in particular with 14484, this association is extremely strong. And it's a little bit less strong with 11778, and there is no association with 3460. Was initially described in groups, in series of few patients, but at the end, a few years ago, with a very strong effort with a multi-center study, we have been able to analyze over 3,000 patients, and this association was very clear. In particular with the haplogroup J1C and J2B. So what it means? It means that if you look at this drawing, essentially all the little numbers that you see are variants that has been inherited from the maternal line, from ancestors, maternal ancestors that have been living thousands of years ago. And over the time, you build up different variants. And some of these variants, the ones that are in red, are actually variants that change amino acids, some building blocks of these proteins where the Leber's mutations are, so they're able to change the pathogenic potential of the Leber's mutation. So in this particular two branches of haplogroup J, J1C and J2B, it happens that these variants are increasing the potential. So families with this haplogroup, they will have more frequently cases of Leber's being affected along the maternal line. But still, even in these families, the penetrance is incomplete. So again, everybody will get the disease. It's interesting that when we studied the rare mutations, also rare mutations are clustering more frequently on haplogroup J. So it is really true that this background has something special in enhancing the pathogenic potential of the Leber's mutations. But let's open a parenthesis now. It has been proposed for a long time that, in particular, smoking tobacco is a trigger for Leber's. And finally, a systematic study with an epidemiological approach has substantiated this claim in England, and was published by Patrick Chinnery and Patrick Wyman. So this study certifies that if you smoke and you have the Leber's mutation, the probability that you will get the disease, the active disease, is much higher. And we also described a few cases where exposure to some particular toxic substances, for example, because of the environment where you work, like vapors of solvents like toluene or hexane, they may act in the same way, enhancing and triggering the disease, enhancing the potential for developing the disease. And the interesting thing that I would like to highlight here is that, again, if you have haplogroup J, the toxicity of these exposures is increased. So these are experiments done on cells, and the viability of the cells, the lowest viability, once the cells are exposed to solvents like hexane or toluene, if you have a haplogroup J, you have the most limited viability. So these cells are more sensitive. So now the scenario is that you need to have the Leber's mutation, but if you have a certain genetic background of the remaining molecule of mitochondrial DNA, this background enhances the potential of the pathogenic mutation, but also enhances the risk if you are interacting with an environmental factor like these solvents. But this is not limited to solvents. The brand new information is that this applies also to tobacco smoking. So if you challenge the cells in culture and you measure the viability of these cells, so how many cells are surviving in your experiment, having introduced into the culture medium tobacco extracts, then again you have the lowest viability with haplogroup J. So the column which are the lowest are haplogroup J. So there is a differential capability to cope with toxic exposure coming from environment based on how variable is your molecule of mitochondrial DNA. So this is another very important concept. And if you test these tobacco extracts on Leber's patients' cells, and you can see that 3460 is the most sensitive because it has the less viability compared to the other two. And it's a matter of fact that 3460, in a sense, is the most severe because lowers the activity of complex 1, while the other two are doing something different. But even with all these variables that we considered, so the primary mutation, the mitochondrial DNA haplogroup, the interaction of both with environmental triggers like tobacco smoking, which is very common, or occasionally with other toxicants, still within the families, not everybody is getting the disease. So we must think that also the nuclear genes are impinging on mitochondrial function in a way that modulates the pathogenic potential of the Leber's mutation. And now we know that in the nuclear DNA, we have about 1,600 genes which are encoding proteins that end up working within mitochondria. So in the nucleus, you have 1,600 genes that are mitochondrial proteins. This is very important because in one of those, maybe you have some variants which, again, are interfering with the Leber's mutation. So in order to study this issue, we have been taking advantage of a very large pedigree that is located in Brazil. And this is Dr. Alfredo Sadun, which, by the way, sends his regards to this audience because he couldn't come over here, but he was supposed to be a speaker today. And with Alfredo, we have been following this big family in Brazil for over 10 years now. And this is the pedigree. These are about 360 people originating from Italy, and I have been able to trace back also the Italian branch, which is still living in Italy. And having such a large pedigree, single pedigree, many of the genetic issues could be solved because it's very informative as compared to small families. That is usually what you see in the common clinic. So if we look at the penetrance issue, so how many people are actually affected within this family along the maternal line compared to the total of the people carrying the mutation, so this is the concept of penetrance, we calculated the general penetrance, and we also considered the penetrance stratified by sex because we know that males are more prone to get the disease than females. And if we break the entire family in single nuclear families, so mom and dad and kids, and if we consider on one side only the families who have a mom who is affected, so with the disease, the penetrance, so the amount of people getting the disease in the next generation, so the kids, is about 45%. So almost half of the kids will get the disease. And if we break this by gender, 60% of males will get the disease and 30% of females will get the disease. But then if we consider the other families, nuclear families, where the mom is an unaffected carrier of the mutation, so she has the mutation, passing the mutation to the next generation, but she doesn't have the disease, then you get a completely different situation because you have a penetrance of 23%. So only 20% of the kids will get the disease, and they will be essentially all males. No female is affected. So this is the advantage of having a gigantic pedigree because you can actually see on the same genetic background what's going on. And this data tells you that on top of the mitochondrial DNA mutation, on top of the mitochondrial DNA background, which is all the same for everybody here, you must have something in the nuclear gene that modulates. And if this something is producing the disease in the mom, it's most probable that also will be inherited by the kids. So you have an increase in penetrance in those families as opposed to the moms, to the females not having the disease and not having this modulating gene. But the point is, where is the gene? Is just one or are more than one? And so let's see next. Obviously, because of the male prevalence, X chromosome has been the perfect candidate to look for. And it's a matter of fact that everybody tried to do that, even us with this very big family. And a few papers came out identifying loci, so regions of the chromosome X where possibly the modifying nuclear gene is contained, but each of the single studies produced a different results. So you have the UK study on the left with one locus, you have the study on the Brazilian family on the right with another locus, and then you have two different loci coming from Chinese families. So essentially, none of us has been looking at the same thing, and so there was discordance between these results. This doesn't mean that in the chromosome X there is nothing. It means that it's very difficult by this approach actually to locate the nuclear gene. But concerning the issue of males being more affected than females, we took a very simple approach. Males are very different from females, in particular from the standpoint of estrogens and the hormonal setup. Females has high levels of estrogens, they have cycles, and males are not so exposed to estrogens. And so what we did, we challenged cells in cultures from labor patients with estrogens, and we measured how the biochemical defect, how the cellular defect due to the mitochondrial DNA mutation was actually changing because of the estrogen influence. And I just want you to focus on one graph, the lower one on the right, which says that the number of mitochondria is increasing because of estrogens. So essentially, you are reacting with a compensatory response to the defective function of these cells thanks to the activation that is produced by estrogens. So this is very important because you partially rescue the malfunction of mitochondria in this way, just activating mitochondrial biogenesis, so making more mitochondria within the cells. So there is a long list of conclusions. The only one that you should take into consideration, estrogens are able to partially produce a compensatory response to the mitochondrial defect. And that's probably a good explanation why you have much lower probability for a woman to get affected. But then, if it's true that if you increase mitochondrial numbers, is a compensatory response that partially corrects the defect, this should apply to everybody. So we went back to test this hypothesis to the Brazilian family, and we also reproduced our experiment in a collection of Italian families. And what we found is that normally in the blood, each of us has a certain amount of mtDNA copies. You know that mtDNA, mitochondrial DNA, is a multi-copy DNA within each cell. So within each cell, you have multiple copies of this DNA. And if you have the Leber's mutation, the amount of this DNA is increased. So spontaneously, the body, the cell, is reacting to the presence of the mutation, compensating just by increasing the amount of copies and the amount of mitochondria. But there is a variability within the population in doing this. So some people is more capable to upregulate mitochondrial biogenesis, probably because of a genetic setup, compared to others. And it's a matter of fact that in the category of unaffected carriers, you have the highest amount of mitochondrial DNA as compared to the affected people. So this is not gender related. This is just that some people, if it's challenged to produce a compensatory response to a mitochondrial dysfunction, is able to reproduce mitochondria and to build up more mitochondria in a more efficient way of someone else. And this probably depends on the genetic background. So within a family with Leber mutation, some people are compensating more efficiently than others. And so there probably will be less prone to get the disease than the others and remain unaffected for the entire life. This applies also to the target tissue. We did experiments on the optic nerve, on the few post-mortem specimens that of optic nerve tissue that we have been able to collect in Los Angeles in Alfredo Sadun's lab. And what this means in terms of optic nerve and retinal ganglion cells. So let's go back to the natural history of how labor develops when a patient loses his vision. Essentially, the first event is that the patient recognizes that can't see correctly in one eye. Usually it's one eye first and the second eye later on, but sometimes it's bilateral in both eyes at the same time. And if you run the visual field, you have the central scotoma. You are all familiar with that. But if you run a new technique, imaging the retina, which is the optical coherence tomography, you may observe on the follow-up of patients that the first place where you lose fibers is on the temporal side, where you have the so-called papillomacular bundles. These are small axons which are providing information for central vision. So that's why if you lose those, the initial symptom will be the central scotoma. And then all the other fibers are swollen, but once the swelling is ending, you lose fibers in the other sectors of the retina. So you lose fibers in the inferior sector and then in the superior, and only on the nasal side you may have some spared axons, some spared fibers. So this is measurable in vivo during the follow-up of the patients in the first 3-6 months of the disease. And this is reflected by what we have seen in the optic nerve specimens at histology. So the wave of degeneration starts from one side of the nerve, the temporal side, and then marches within the nerve until only the nasal side is spared. And what imposes this pattern? Why are not axons dying at the same time? So what we found by counting the axons and by measuring the diameter of the axon is that actually the first axons to die are the smallest fibers. So these axons that are very small. And papillomacular bundle is particularly built up by small axons. And then also the medium-sized axons and the larger-sized axons get affected later on. But in the category of the larger axons, you have the most of those which are remaining, and they're still providing you some vision in the periphery of the visual field. And why is that? It relates to the caliber, the diameter of the axon relates to how many mitochondria you can accommodate within the axon. So if you have a crisis, you build up more mitochondria as a compensatory response, and they get into the axon. But if the axon is small, you have a smaller number of mitochondria that can be accommodated. And so these axons are the most sensitive to a mitochondrial dysfunction. So the pattern of neurodegeneration follows the axonal diameter and starts from the smallest fibers and marches through the medium size and the bigger ones. And the smallest fibers are the most vulnerable in maintaining the energy supply because their volume is limited in accommodating more mitochondria as a compensatory response. So now you understand that making more mitochondria is important, but also within this particular tissue, the space where you can accommodate these mitochondria, if it's limited, is a failing compensatory response. All these issues has been recently reproduced in a mouse model, and this was presented last year by Dr. Wallace, and we are intensively studying this mouse model because all the issues and the mysteries that we have can be actually nicely solved, probably producing the appropriate experiments on the mouse model. And finally, there is one other element that produces the predisposition to get affected. And this is an anatomical element. So if you have a small optic nerve, you are more prone to get the disease than if you have a larger optic nerve. And probably this deals with, again, the issue of space. If you have a crowded optic disc with many fibers getting in, very crowded, if you swell them because of the compensatory response and you fill them up with mitochondria, which produces the swelling probably, obviously if you have more space, your compensation will be more efficient than if you have less space. So a few more slides to tell what we're doing now to locate the genes in the nucleus in order to solve the problem of what is modulating the penetrance, and a few more slides on only one issue about therapeutic approaches. So very quick, I will tell you that we have had a big grant approved by LHON, which is an Italian agency for genetic disorders. And what we're doing, we are running expression studies. So we're looking at what genes are expressed in labors which are affected versus labors which are unaffected. So people carrying the mutation but not having the disease. Because maybe in that way we will locate the right genes making the difference. We are also applying modern techniques of sequencing, so we're literally sequencing everything to see if there are variants which are more associated with the affected people as compared to the unaffected carriers. And we're taking advantage of the big labors family from Brazil to run more linkage and association studies. And we also sequence directly genes that we think could be interesting as candidate genes. So the Affymetrix expression chip produced some results, and we now have a bunch of genes that are interesting, that could be contributing to the penetrance issue because they are more expressed in one category, the affected, and less expressed in the others, or the other way around, depends on the genes. The mito-exome, so the sequencing of all mitochondrial genomes, the 1600 I was mentioning before, is also producing some results. And the Brazilian pedigree has been a failure in terms of linkage analysis, because linkage is a technique designed to locate monogenic disorders. So if one gene produces the entire effect, you will get it by linkage. But if you have many little effects for many different genes, you will not see any signal. So we have been running association studies, and association studies produced, this is called Manhattan plot. Essentially, all little dots are different variants, and those which are in the upper part of this red line are those which are significantly associated either with unaffected carriers or with affected people. So again, these variants and the genes that are holding the variants are probably involved in this penetrance issue. But because of the environmental exposure and triggers as confounding factor, as well as age, this is a disease that is age-related, and because of sex, the male gender is more prone to get the disease, we also had to consider these covariates in our calculations. And it's interesting to note that if you look at the people within the Brazilian family classified by mtDNA copy number, so the amount of copies of mitochondrial DNA that these people has in the blood, over 500, the probability of being affected is extremely low. So the black is carriers, and the first column is all black. So all people with over 500 copies are actually carriers. But then if you are less than 500, gender comes into play. And obviously, if you're male, you are almost certainly be affected as compared if you're female. And but if you put smoke into play at this point, you see that if you smoke, most of the cases, you will be unaffected, and if you don't smoke, you'll be a carrier. But if you combine smoke and mtDNA copy number, something really interesting comes up. So smokers have a less mtDNA copy number. So essentially, if you smoke, probably you limit the capability that you have to compensate up-regulating the mitochondrial DNA copy number and mitochondrial biogenesis. So now this information means that probably we're still looking for nuclear genes, but probably the triggers, the environmental triggers, are a big chunk of the predisposition to be affected. So the strong message here is that you don't have to smoke. So here the conclusions are that you have to have one of the mutations. This is the predisposition to be affected, but is not that only factor is not dictating if you're affected or not. mtDNA haplogroup is important. Anatomical factors are important. Environmental triggers are important. Capability of being very efficient to upregulate mitochondrial mass is important. And finally, we are now looking for the nuclear genes that might be the last piece of the puzzle that we need to fill up. So, based on what we know, these cells, retinal ganglion cells, die because you have an oxidative phosphorylation defect due to complex 1 dysfunction. The mutations, Leber's mutations, are located in complex 1. As a consequence, you produce less ATP, but you also overproduce reactive oxygen species. And this, combined with the mitochondrial dynamics, the way the mitochondria are distributed within the axons, probably makes part of the mechanism that leading to death, and and the cell death is probably a silent death with no inflammation by apoptosis. So, based on what we just said, I will focus on a few slides about how we can artificially increase mitochondrial biogenesis as a compensatory therapy to keep people not affected. And I'm not touching all the other points because this will be developed by Patrick later on. So, just in the last few months, actually I would say weeks, 2 very important papers came out. One is from Massimo Zeviani in England, and one is from Anu Suomalainen in Finland. And they're both saying that for myopathies applies the same principle that mitochondrial biogenesis is a compensatory mechanism that makes things better. You may use a particular biochemical pathway activating SIRT1, which orchestrates a compensatory response. And I'm not getting into the details of this, but there are 2 ways where you can actually activate SIRT1 through NAD, and this is nicotinamide riboside, or you can inhibit PARP, which is another factor. And in this way, if SIRT1 is activated as a cascade effect, it activates PGC1 alpha, which is the master regulator of mitochondrial biogenesis. So if you increase PGC1 alpha, this co-activator, all the mitochondrial biogenesis program is being activated. So using either nicotinamide riboside or PARP inhibitors could be, we need to do appropriate studies, but could be a strategy. Our strategy is coming from another direction, which is the estrogens. We obviously cannot give estrogens to people, in particular to males, but there are some compounds which are called phytoestrogens that are retaining part of the interesting properties that estrogens have that we would like to exploit. And combining essentially 3 different phytoestrogens, which are called genistein, didazein, and equal, all three of them combined are actually producing effects very similar to estradiol, which is the classical beta-estradiol, which is the classical estrogen hormone. So we have been running a number of experiments, and this is actually a project that has been supported by UMDF with a grant to Carla Giordano in Italy. And you have some results. Viability of cells, this is normal cells. Viability of Leber cells is much less than half, so cells die much faster in certain conditions. If you support these cells with estrogens, you actually recover here. But we say that we cannot give estrogens to patients. So if we give each of the 3 different phytoestrogens alone, we have a partial compensation, but all 3 of them synergize and are actually reaching the same effect as estrogens in cell survival. So this is very promising. And estrogens increase mitochondrial DNA copy number and mitochondrial mass. The red dots are mitochondria. On the left side, you have untreated, and on the right side, you have treated. So you can recognize that you increase the number of mitochondria within single cells using this combination of 3 phytoestrogens. And you also increase all the modulators of mitochondrial biogenesis. Here you see how you increase PGC1 alpha, which is the master regulator, but also downstream other factors like TFAM and nuclear NRF1 and others are being increased, upregulated. So it all works in the same way. And the red stuff are cells with oxidative stress, and if you expose the cells to the combination of phytoestrogens, you don't have oxidative stress anymore. So it looks like this is another possibility, and it still follows the same concept. If you increase the capability of building up more mitochondria, you are partially compensating, and lucky enough, Leber's mutation is a weak mutation. And it's a matter of fact that many people are actually living with the mutation without having the disease. All this has been done by this girls. This is the Carla Giordano's lab, and Carla is there. And the take-home message at the end of this presentation is that, again, you need to have one of the primary mutations to be predisposed. And if you have a certain haplogroup, you're more at risky, on the risky side. If you smoke and you have the haplogroup, you're increasing a lot the probability to get the disease. If you have a small optic nerve, you are more prone to get the disease. If you're not able to compensate efficiently, you're more prone to get the disease. And we're now looking for the nuclear genes. Hopefully we'll come up with some results. Once we located the nuclear genes, our intention is to build up a scoring system where if you have smoking, a nuclear gene, haplogroup J, a small optic nerve, you have the highest risk. And this will be a number predicting if you're very close to get the disease. And if this scoring system gets validated, we will be able to say to people in advance, look, you are getting really close to the point where you will develop the active disease. And that people should be treated in advance because, as I said at the first slide, once you get the disease and you go to the doctor, it might be quite late. So I thank you for the attention and all the collaborators, many, many people. This is just a partial list. And obviously, in particular, are the 5 people working with me in the lab. Thank you very much.
Thank you, Dr. Carelli. I suspect that, well, did anyone understand everything he said? But I love listening to him. It's like he's singing. It's wonderful. You'll be able to watch it again when the video is loaded on LHON.org. So you'll be able to go back, review, and sort of pick up a few of the things you might have missed the first time or the second or the third. I suspect there's a lot of questions. However, we're going to have another session after lunch with Dr. Yu-I-Man, and then after that we're going to have a whole half hour just for Q&A for the two of them together. So if you could hold your thoughts, hold your questions, and we'll cover questions on both topics, and then now we're going to move to our next panel, and we will have him back later. Thank you.
Okay, thank you.